So a little, just before we get started, I tried this in the case room. I had these poll everywhere kind of questions in there, and just from a screen sharing perspective, the poll doesn't like come out up per se. So the question will be there on one of the slides. There'll be a link to the poll everywhere. Like questions, and it's the same link for all of them. They'll just kind of cycle through as they get as they start. And so what I would ask you to do is when you see that the link, just put that in your phone if you're using a phone, and then that way you can vote. If it gets a little to be too much, we'll just abandon it. So, but just some ideas. So, all right, Sakin, can I get going, I guess?
Yeah, for
all right.
sure. Yeah.
All right. So, so thanks again. So session 4, so foot and ankle injuries, avoiding landmines. So this is my wonderful panel. So Jim Lachman from St. Luke's University, I see his face on there. So thanks for joining us, Jim. Bobby Nadeau from Einstein, I see him there. Nadeau can do, very good. I like that. And then
I'm on my kid's computer, so I apologize.
I love it. And then Joe O'Neill, or I see, what's the Jake? I guess you go by, huh?
Yeah.
Or is that your son? It's so confusing.
No, it's me.
Right? And so Dr. Neal from the Rothman Institute. So these are wonderful panels. So 30 minutes to go through all the foot and ankle landmines that we can avoid is just not going to happen. So, we kind of put together choose your own adventure, and we'll see how it goes. And so with that, these are kind of some of the objectives for the session. Discuss the fixation strategy for common foot and ankle injuries, and then understand common controversies and potentially pitfalls for these injuries as well. All right, so choose your own adventure. So you can see the link down there at the bottom, pollev.com/Derek Donegan 241. This will be the same link for all the questions. And so, if you put that in your phone or a computer, we'll see what kind of feedback we get from this. So these are the cases we have to go through. We will not get through all these. If we get through 1, maybe 2, that would be awesome. And so please, you got a Mason-Neuve, a trimal, a transitional ankle fracture. If you don't know what it is, that'll be kind of fun to talk about, and a scrambled foot. So let's see if this poll works. All right, so go ahead and put your things in there. I give a couple seconds here. It's working. I know you probably can't see it, but I will just tell you what it says. So you have to trust me. Or can you see it? I don't even know. All right, give another 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. All right, very good. So the Mason-Neuve and the, let's see here, hold on a second. There we go. Mason-Neuve and the trimal got going. So let's do the Mason-Neuve first, because I think this has a lot of really kind of good discussion points. And so some things to talk about, and to be quite frank, we do these OTA sessions every Wednesday night, kind of like fracture conference things. And on Wednesday night we had a Liz Frank that was presented, and the discussion between trauma and foot and ankle surgery was awesome. And I think this one will be very similar. So 35-year-old male with a right ankle injury. One of my panelists, maybe Bobby, what do you see?
So this is an AP lateral image of a scalp immature individual with what appears to be widening of the tib fit space, lining at the medial clear space. I'm not seeing anything actually physically broken on this image, so I'd love to see something up high. See proximal fibula fracture, something within the view here.
So here's a splinted film. You can kind of where my mouse is, maybe right here, a little fracture line. Something very subtle, though. I would agree. It's not very, very impressive. So what are your thoughts when you see this? What goes through your mind immediately?
My first thought's going to be about the cartilage injury that the patient would have sustained with the talus, because obviously whatever view you're seeing here, it's not the worst of what it was. So at some point, that talus was likely completely out from underneath. Yeah, might have gotten scraped on the way back in. So first thought's the cartilage injury, and then obviously the significant instability of the joint itself, and recognizing that this is one that I'm more than likely going to end up fixing surgically. I don't believe in managing non-operatively, especially if they're looking this way.
Yeah, I kind of agree, especially in a 35-year-old, right? We're talking about restoring function and getting people back to life. So these are the splenic films you can see. Again, very subtle. I think one of the things you mentioned very eloquently right away is like, you didn't see anything else, right? And so you want to see something proximally. So, the tib fib joint, the entire way, it's a ring, right? And just like pelvic rings and every other ring in our body, or forearms, it's very odd for it to be injured in one spot. So, I know many of you on this call know Chip Rout. He has this saying of seek out disease. So these are those injuries you need to start seeking out disease and look for that second injury to see if it's something you need to take care of. So syndesmotic injuries in general, this is still, I mean, I think most people would agree, still a pretty hot topic for some, debate of what to do with them and the frustration on how we take care of them. Some of the things, how do we know that we're getting these things right? And then, maybe we need to be fixing some of these associated injuries, maybe not. The goals, just like almost any other fracture pattern and injuries, want to restore length, alignment, rotation, get the fibula, anatomically put back together, reduce it in a sagittal plane, get stable fixation, whether that's, rigid or dynamic. I think that's debatable. And then maintain the position of the talus under the tibia anatomically. So a couple of things to think about. So obviously fibular length, there's the idea of the dime sign, right? Making where the fibula and the talus kind of meet up. The idea of the fibular nose lining up with the joint surface. So a couple of different ways to take a look to make sure your fibula is at the right length. Here, obviously, you can see that it's shortened. The dime sign is off. Your fibular nose is migrated proximal, and that's going to start giving you some mortise instability. The other thing that's really important to think about is the rotation of the fibula. And I think this is something that's a little bit less talked about. We think a lot about length, not as much about rotation, but here you can see the different profiles of the fibula radiographically and what it looks like when it's externally rotated, when it's fixed anatomically, and when it's internally rotated. So looking at these subtle clues can be very helpful in that. So here's our patient again. And so the next poll. So how would you approach this this injury? Would you open it or would you close it? So looks like it's working. So people are give an answer here. Give a couple of seconds.
Derek, can you read out or show your polling address thing again?
I can try. It's I struggle with this in the other one. Let me see if this works.
Because it was a bit. It was. I don't. And the other thing is, I don't know if you know, we didn't see results come up on our screen. So whatever you're seeing, we didn't see.
I know that's why that's part of the the sharing.
Okay.
The issue. Anyways, all right. So
if enough people are responding, that's fine. I just
yeah, I'm using it to kind of guide to the discussion.
Never mind.
Unfortunately, so all right, here we are. All right, so it was probably about 60% open and 40+% closed. So, Jim, what are your thoughts about the syndesmosis? How are you addressing this injury when you take them to the OR? How are you reducing this thing?
I think since your fibula is a length stable fracture, sometimes you get these Mason-Neuves where the fibula is very short, and even though we're a little zoomed out here, you can, I guess, convince yourself by looking at the fracture site that you don't have a length unstable fracture here. Your most important thing is on the sagittal plane, and so you have to figure out, whether it's closed or open, a method to get this this fibula back into the incisura in an anatomic way. And so what I think about is you can do this through a lateral approach, just going over top of the fibula and looking at the anterior edge of the incisura where the fibula meets that. It's through the same incision that you plan to put your hardware. Now, I do, in a case like this, I would do a plate with two divergent tight ropes, one that goes in the trajectory of the standard screw, and then another one that goes slightly diverted to give you that A to P stability. And I do these open in a way, but just by looking at my incision, you wouldn't say that I did anything to open this up in a more dramatic way. You can do this and see what you need to see through a relatively reasonable incision on the lateral side of the fibula.
Yeah, I think those are all really good points, Jim. I think so you can do this with direct visualization, but not necessarily a very large open dissection is what I'm hearing, and assuring that you're getting it right. So just from a literature perspective, I think it's one of these things that we talk about often, and so should we do it open? Should we do it closed? Kind of to Jim's point, with some direct visualization, the rate of malreduction tends to go down, right? And that's been described, in the literature. We still aren't perfect at it, and so some might argue that maybe it doesn't matter as much, but there is a decreased rate of malreduction if you do something, i.e., open or directly visualize where you're putting the fibula. Many of the panelists say there's no way I don't open this. I do this closed every time, and I use other methods to make sure I'm reduced.
No.
Bobby or Jake, no. Always
No.
open, always looking at it.
Yes.
I always open as well.
All right. All right. So next question: how are you going to reduce this? So are you going to use large periarticular reduction clamps, use a Weber clamp, or use just a thumb and K-wire? Again, apologize you can't see the results, but right now thumb and K-wire is winning, but it's pretty close. So I think this will be interesting to see. All right, so thumb and K-wire and the Weber clamp were just about even, right around 40%, like 41 and 39%. Large periarticular reduction clamp was 21%. So, Jake, what are your thoughts? How do you reduce this?
Generally for an acute injury, I like to do just thumb and K-wire. I'm like Jim in that I typically for late length stable injury like this, we'll put a small plate with 2 suture button devices across. And so in that set, there are some wires that you can use. And so I'll use my thumb to do the reduction and then hold it with the 2 guide wires. If it's a revision situation or a more chronic injury where I have to go in and clean out the syndesmosis, sometimes I will use a clamp if I feel like I can't get it fully reduced using my thumb. And the clamp that I would use is a lot of times just dependent on the size of the leg, but usually something like a Weber clamp is sufficient for me.
That's great. So when you're considering clamps, I think a lot of us, anybody on the panel, and anything else, do most people use just your thumb and a K-wire, or you're breaking out something else? Bobby,
I've gotten even away from that. Honestly, I think in a situation like this, if you get to it relatively soon, you're not going to have any trouble getting this back into position. So if you get your first suture button device in the right trajectory, and we can talk about what that trajectory is, then you can actually hold a reduction. So you obviously have to have a surgical assistant. I have a PA. I also have residents, so that can be helpful. If you're alone, this may be a little bit more challenging. But just like you would reduce this fracture in the emergency room to try and close down the medial clear space, you dorsiflex and then you put in hindfoot varus, and then you use the suture button device to actually close down your syndesmosis. So I don't use a K-wire, but I guess if you're calling that the thumb technique, that's pretty much what I do. So
yeah, I like that. Go ahead, Bobby. Sorry.
I was going to say, so I kind of evolved. I started out using primarily clamps just to make sure that I was holding it well. I was off sometimes by myself, but I've evolved to primarily now I am just thumb and K-wire. one little caveat, I guess maybe we'll talk about this later. I don't really use suture buttons for fixation. Just from a financial standpoint, I have to factor that in, unfortunately, sometimes it's caring for folks. I still go with the classic screw plate construct.
All right. Yeah, we'll definitely get to that in a couple slides. So, but I think those are all really good points. I think something to consider, just remember, you know, if whatever technique you're using, just where the fibula typically sits in suture, and that there's different anatomies of the fibula as well, right? And then different anatomies of the incisure as well. So you could have a very shallow one, a very deep one, a retroverted one. So there's different morphologies. But if you are going to use, you know, clamps or something to assist, you know, understanding that it's easy to dial in malrotation or malreduction. Let's see. There we go. All right. So this is what I did for this individual. I used a 1/3 tubular plate and two fully threaded quadricortical 3/5 screws. So how
are you able to go back to that, Derek? So since you have 3 foot and ankle panelists on a trauma symposium, I feel obligated to bring up something that so I guess a couple of years ago, the OTA and the AOFAS had a combined specialty day session where they went over all of these controversial things that foot and ankle surgeons do and that trauma surgeons do, or kind of, you know, where we're drinking the Kool-Aid one way and you guys are drinking the Kool-Aid the other. So if you're looking at your central x-ray there, and once again, I'm looking at this on a laptop screen. It's not a high resolution. And I was looking at it on my phone when you sent it to me earlier this week. And you see there, I see a slight gapping in the medial joint. Now, not the medial clear space, but a little bit of talar tilt here. And so if this is a stress x-ray, you have definitely corrected the syndesmosis gapping. But I would argue that, is there a deltoid ligament injury here as well? So is the deltoid something that the trauma surgeons are thinking about at all?
Yeah, I think that's a really good comment. You know, I think just like Bobby, I have evolved over the years, and I think take a more systematic approach to taking care of these. And so I would tell you that today, the deltoid ligament is on my mind. How often do I do something to it? Not very, but it is on my mind. When I did this surgery, it was not on my mind.
Yeah, I can't tell. Like I said, the resolution of this image, I can't tell if that's real or not. You know, obviously it's a very angular thing if you're getting it in the operating room, but I think the confusion historically was that people were looking for medial clear space widening and suggesting that the deltoid didn't need to be fixed. But I would argue that after you've fixed your syndesmosis, that looking for talar tilt or medial gapping of the joint space is what you're going to see if you have a superficial deltoid injury, which is the only one that you can repair, a superficial deltoid injury. You know, foot abduction or forefoot valgus, however you want to describe that, is something that I think presents itself later. It's difficult to assess that in the operating room.
Yeah, I would agree. So to your, just to put your mind at ease, being a foot and ankle surgeon, and I'm wondering what us trauma people are doing. There's a really nice AO talk by Matt Camuso, one of the trauma surgeons up in Maine, actually talks about that kind of staged approach and doing stuff to the deltoid ligament. So it's definitely on our mind. All right, next polling question. So now that we did this, how do you check your reduction? So intraoperative fluoro compared to the contralateral side, intraoperative CT scan, or it doesn't matter because 16 to 15%, we get it wrong anyways. All right, we'll end it there. So intraoperative fluoro had 56% of the votes. Intraoperative fluoro compared to the contralateral side had about 43% of the votes. Nothing for intraoperative CT and nothing for it doesn't matter. Jake, what do you think?
So I'm intraoperative fluoro. I will say, kind of like I said before, I'm approaching this in an open fashion. So a lot of the check of my reduction is just directly looking at it. But once I've done that and put my provisional fixation across, I will check it. And I think it's important to check it a multi-planar view. You know, when you're a young resident, you're just looking at these and your main concern oftentimes is AP and particularly the mortise. But now there's argument that that sagittal view, that lateral view, is even more important. So I think it's very important to get a perfect lateral on these before leaving the operating room to make sure you have it reduced on all planes.
Yeah, so I think that's good. So this was a nice, just kind of, technical systematic evaluation of the synostosis published in JOT in 2012. Again, I think what I'm hearing from our panelists is that there's a couple different ways to do it, but you should do it, in a systematic way so you don't miss anything. So here's obviously a cotton test showing some instability, and then looking at the fibular length compared to the contralateral side. And then I think, Jim, you talked about the sagittal balance, right, of that fibula, understanding kind of where that is. And, so this paper advocates using, contralateral fluoroscopic imaging to just to compare, to make sure you're getting it somewhat close. Anybody have considered or thought of using like intraoperative CT? There's been a couple reports about that, i.e. like the O-arm or anything to that nature. Has anyone used that or thought about using that, or not really, because most of you guys are doing this open?
I don't use it. It's not really an option, again, from a cost standpoint, radiation standpoint. I don't know that it would add a significant amount of value. As you mentioned, we use it 16% of the time anyway. And then if you already have it malreduced, and you're close, are you taking the screws out, and how are you adjusting your fixation at that point? What's going to change on what you're going to do in the room?
Yeah.
So those are some of the things that I would question about using it.
Yeah, I think those are all good points too. So again, if you're not sure, CT, you can do other things to evaluate it afterwards. So this is our person. So I think we have some, maybe introduce some bias here, just given what other people have said already on the panel. But how would you fix this? You saw what I did. You heard what other people would do. This is like one of those studies you have to end early because it's so obvious what the results are. So 70% of people talked about using dynamic fixation or some kind of like suture button. So before we kind of go through this slide, I think, we have at least some dissenting opinions here. I know it sounded like Jim, suture buttons, Jake, it sounded like something similar. Bobby, screw fixation. So Bobby, why don't you take it first, and why screws?
So my main thing in terms of why screws is cost. So we have to factor that into my institution pretty regularly. I explain to most patients that I'm not planning to take the screws back out unless they bother them. I'm fine with the screws breaking, as long as they're not causing a discomfort issue. If they are bothering the patient, then I will go back and take them out. Obviously, there's a question of a second surgical cost, but I find that I'm taking fewer out than what I'm leaving in.
You're taking screws out. How about Jim or Jake? Reason why you're doing tight ropes or some kind of dynamic suture button fixation?
I will use a screw from time to time. I'll use many screws in diabetics, obviously. Although I always put a tight rope underneath the screws so that when all the screws break, the tight rope is still there in the diabetic. I think cost is an interesting point, simply because if you are planning to take the screws out, so if you are going to take the screws out, that second surgery negates the cost of the tightrope, and it all depends on your institution's specific negotiations for the cost of that tightrope. If your tightrope is anywhere between $900 and less, they've actually shown that revision surgery ends up being more expensive than to take the screw out. So if you're getting a tightrope for $1,500, obviously, then maybe you're not having that type of problem. But the benefits of the tightrope to me are that this is a dynamic structure. This is a joint. So, if you want to be a closet fuser and start fusing these joints with screws, then that's fine. But it's this fibula externally rotates with dorsiflexion. It has anterior and posterior translation through range of motion. It is a dynamic structure, and I just feel like, even if the screw breaks, obviously you're restoring that motion. So just getting that motion back to the ankle, a painful screw always has to come out. A tightrope generally tends not to have to come out, although you can malreduce with a tightrope as well.
Yeah, it seems like some of the literature would suggest tight ropes are a little bit more forgiving, but it's you can still mess it up, as I'm sure we all have. Literature supports, you know, if you look at this, I think cost is an interesting conversation to have, and it probably is negated when you start taking out, and it depends on what your negotiated costs are with the hospital system. But, you know, from a functional outcome perspective, there are some, you know, in the literature at least, some benefits to using dynamic fixation. So controversies, and we'll kind of start to finish up this case particular. You know, as you can see, there's a little bit of discussion, dissension amongst the group as far as what to use. And I think that bores out with the controversies in the literature and just among opinion. So screws only versus plate and screw, 1 versus 2, 3 versus 4 cortices if you're using screws. What do you do with the screws, I think, is a big question. And then if, you know, using dynamic fixation. So just out of curiosity's sake, when you, I'll pose this to Bobby, when you are doing screws or when you use screws, what do you do with them?
So typically, you know, if for an isolated syndesmotic injury, I'm going to do a plate and 2 screws. If I'm working through a fracture site, if it's someone that I actually start to factor in, if patient factors, weight, diabetes, someone who's smaller, lighter, and, you know, in better shape, which is the very rare patient, I actually sometimes will use 1 screw, just to make sure to that point that I know it will eventually work, so that they can restore that motion like Jim was mentioning before. But typically I also will drill 4 cortices, place a tricortical screw, so that I essentially have that scar on the far side if the screw breaks and I need to go get that fragment, so that I can hunt it down from the medial side if need be.
Yeah, I like that. I go back and forth using both dynamic fixation and screws. When I do use screws, I do a very similar technique. I drill 4 cortices and typically only put it in 3, but I think that's very beneficial.
I'm sorry, and one more point. I usually use a 3/5 screw, just to, for that, again, that point about trying to get it to break.
Yeah, I do too. All right, so this was a nice, you know, current concepts, you know, although written by a trauma surgeon out of Minnesota from 2014. It's a nice read, and I think does highlight a lot of things we just talked about for those if interested in reading a little bit more about this. Sakib, how much more time do we have? About like 15 minutes?
No, we're done.
All right, perfect. There we go. All right, well, I figured.
I was just gonna say, yeah, it's time to wrap it up. But
I figured we'd probably only get through 1 case. Sorry for some of the technical snafus with the questions, but I think it's just a Zoom thing. We'll have to figure that out better next time. Any parting questions or words from my panelists? Jim, first.
Yeah, I'll just do a quick point. On a lateral x-ray, intraoperatively, if you're going to use a screw or a tightrope, a good way to tell whether or not you have a good trajectory, so the least likely to malreduce the fibula and the incisura, is to make sure that on a perfect lateral x-ray, the button on the suture button or the tip of the screw is halfway between the anterior edge of the fibula and the anterior edge of the tibia. And maybe that's a common point. Maybe everybody already knows that. But if you check a lateral x-ray that has a perfect lateral of the talus and your suture button is way posterior or your screw is way anterior, you know, vice versa, whatever, then you can consider that maybe that trajectory of the screw is going to malreduce your fibula. Maybe the trajectory of your tightrope is going to malreduce your fibula. So trying to get that halfway between, on a perfect lateral, the anterior cortex of the fibula and the anterior cortex of the tibia.
Excellent. Bobby, any 2 seconds, any last second tips?
I would just echo Jim's point about the deltoid and talar tilt. It's something that, again, speaking of evolving, as you've been in practice for a little while, I've definitely evolved to fixing a lot more deltoids, because from the long-term standpoint, the sequelae of it can change a patient's outcome, especially young active patients. So really take a look at that and consider fixing the superficial deltoid.
Great. And then Jake, any words of wisdom for everybody?
No, I think just echoing kind of what was said earlier about the deltoid. And then also I think it's very important when you're treating these injuries to you know, kind of tailor your approach to your patient and not be an all or none kind of person. So you want to be ready to use your suture button type fixation, but also be willing to do screws. You got to do whatever's best for your patient.
Very good. All right. Well, thank you very much. I appreciate everybody's time, and hopefully got a nice little talk about the syndesmosis. So thanks, Sagib.
Thank you.